All right, everyone. So I think we're going to get going. Thank you all so much for joining us bright and early today. So welcome everybody to this training on the role of nurses in recognizing and addressing oncologic emergencies in leukemia and lymphoma, febrile neutropenia, which is organized in partnership with Princess Margaret Cancer Center. Today, Jane Lee and Melissa Lowe will address this last training of a series of 4. So to get us started, my name is Charlotte Hall-Coates, and I'm the Community Services Lead for the Atlantic region with the Leukemia and Lymphoma Society of Canada. Since there are quite a few of you joining today, we invite you to type your questions and comments into the Q&A box of your Zoom webinar panel throughout the presentation. An LLSC staff member will monitor the questions, and I will read some of your questions aloud at the end of the presentation during the question and answer period. Today's training will be recorded, so you can come back and watch it again on our continuing education platform. Before we begin our main presentation, I'd like to share our mission and highlight some resources that might be helpful to you or patients and caregivers that you are supporting. Next slide, please. At the Leukemia and Lymphoma Society of Canada, our mission is to cure blood cancers and improve the quality of life of those touched by a blood cancer and their families. We offer a wide range of programs and services to help address the needs of the blood cancer community from coast to coast. Next slide, please. As part of the community services team, community services leads are here to listen attentively and with compassion to the challenges of the blood cancer community. We can help assist patients and caregivers in finding information specific to their type of blood cancer or treatment. We also provide assistance in helping them to get organized, to manage and take charge of their care, and we can identify services that would be beneficial to them. Visit bloodcancers.ca to find the contact information of the community services lead in your area. Next slide, please. We offer a continuing education program that you can join free of charge. You can register for one or more trainings that you can do at your own pace and receive an electronic certificate of participation. All sessions are designed and offered by experts. We have 1,000 healthcare professionals who are using the platform, and there are currently 40 trainings available. This includes trainings on blood cancer, treatments, psychosocial aspects of cancer, and much more. Also included are the 3 previous training courses offered in the series, the role of nurses in recognizing and addressing oncologic emergencies in leukemia and lymphoma, presented by Graham Dozwa, Cindy Murphy, and Matthew Somerset, which are all now available on the platform. We add trainings regularly, so don't hesitate to register at bloodcancercontinuingeducation.ca or by using the QR code on the screen there. Next slide, please. LSC is advocating for equitable and timely access to treatment and cancer care across Canada. As blood cancer treatments advance, it is crucial to prepare our healthcare system and drug payers to help make these treatments available in a timely manner. LSC is committed to engaging with the key stakeholders within the healthcare system and within each province to ensure that the needs of the blood cancer community are being met. We also offer individual support to ensure everyone has access to care and treatments no matter where they are located. We also work to empower individuals affected by a blood cancer to be effective self-advocates. Don't hesitate to reach out to us if you have a patient or family who's having difficulty accessing a specific service, medication, or clinical trial. We are here to support them. Next slide, please. So it is now time to introduce today's speakers, Jane Lee and Melissa Lowe. Jane Lee is a nurse practitioner at the Princess Margaret Cancer Center. Her interest focuses on improving supportive care and quality of life for patients living with hematological malignancies. And then we also have Melissa Lowe, a clinical trials pharmacist in oncology-hematology at Princess Margaret Cancer Center. Over to you both, Jane and Melissa.
Thank you, Charlotte. Can you hear us well?
Yes, give a thumbs up if you can hear us. Okay.
Okay. Perfect. Like Charlie said, my name is Jane Lee. I'm a nurse practitioner and I work at Princess Margaret Hospital. And my trusty partner here, Melissa, she's an amazing pharmacist that works with me as well. Today, our topic is about febrile neutropenia. And just quickly, some learning objectives. We'll go over the physiological background for febrile neutropenia, some of the risk factors and potential sources of infection. What are the important nursing considerations, some initial investigations and management. Melissa will talk about the pharmacological considerations and primary and secondary prophylaxis. So why is this topic important? Febrile neutropenia and sepsis, as you probably already know, is the most common oncologic emergency. And infections are actually the primary cause of morbidity and mortality in patients with cancer. About 50% of the patients with febrile neutropenia actually have a hematologic malignancy. And out of all the patients who die from febrile neutropenia, 70% also have a hematologic malignancy. So as you can see, this is quite a crucial topic to discuss. And when a patient does present with febrile neutropenia, the most important management is actually starting empiric antimicrobials within 30 minutes to an hour of symptom onset. So time is of the essence here. Just a little background. You've probably seen this diagram ad nauseum, the hematopoiesis diagram. I'll just go over it very briefly. So all the blood cells in your blood comes from the bone marrow from a multipotent stem cell. The neutrophil specifically comes from a myeloid blast, a myeloid progenitor. It's right here in the red box. It's actually the most common white blood cell found in the body. So it takes up about 70% of the white blood cell count. And it's differentiated from by being stimulated by the granulocyte colony stimulating factor, also known as GCSF, as you've probably heard of already. It's one of the 3 types of granulocytes, and it's one of the most important players of your innate immune system. So it's one of the first lines of cells that are recruited to the site of infection. One of the mechanisms that it uses is through phagocytosis of pathogen particles, so fungal elements and bacterial elements, and it uses the granules, the enzymes in the granules of the cell to break down those pathogens. It also releases cytokines at the site of infection, so it can cause and trigger an inflammatory response. So not only is it an important role in the immune system, it also sometimes plays a role in inflammatory diseases. So the normal white blood cell count ranges from 4 to 11 times 10 to the power of 9 cells per liter. And then ANC, which means absolute neutrophil counts, just a fancy word of saying the neutrophil count. The normal range is 2.5 to 7 times 10 to the power of 9. So what is the clinical definition of febrile neutropenia? There's 2 elements to this. First part is fever, febrile, temperature over 38.3 degrees Celsius, or temperature of over 38 degrees Celsius for greater than an hour. And then the second part is obviously the neutrophil count. So ANC of less than 0.5 would be considered neutropenic, and even ANC of less than 1 with an expected decline to under 0.5 within 48 hours. So I'm sure a lot of the patients that you guys see, lymphoma, leukemia patients, will fall under this category with low neutrophils. And when I talk about neutropenia, neutropenia is just a fancy word of saying low neutrophils. There is a grading system from 1 to 4, or from more mild neutropenia to more severe, and that ranges from 1.5 to less than 0.5. So what are the risk factors that put patients at risk for developing an infection or getting febrile neutropenia? We can divide this into 3 major categories. The first one would be patient-related factors. So in literature, it's seen that older age, basically over age of 60, having the female sex, low body surface area, poor performance status, and poor nutrition all puts the patient at risk for developing an infection. And any comorbidities the patient may have. So chronic diseases and any kind of organ dysfunction really puts them at risk. Disease-related. So this you probably already know. Basically, any kind of bone marrow involvement means that the patient's blood cells are not properly developed, and they're probably at risk for prolonged myelosuppression, meaning low blood counts. Sometimes if you see a patient with high LDH on diagnosis, LDH is lactate dehydrogenase. It's an enzyme, and it can be a marker of high tumor burden. So that can also put them at risk for developing an infection. And then treatment related. So chemotherapy, as you know, puts them at risk for infection, but specifically myelosuppressive chemo. So a lot of the leukemia patients specifically, their chemo is very myelosuppressive, and the intensity and duration is really the factor here that puts them at prolonged immunosuppression. And even radiation some of the lymphoma patients get can put them at risk. Any previous infections and use of antibiotics, can cause resistance, and that can be also a risk and can make it very difficult for us to treat these patients. Extended hospital stays, nosocomial infections, ICU admissions, and then finally any kind of central lines or even peripheral IVs, since the direct access to the patient's blood puts them at risk for febrile neutropenia. So now I want to talk about the sources of infection. Basically, any entryway to the body is a potential source of infection, and you can think of it by system. This is just a very simple diagram that shows you all the different ways that a patient could get an infection. So in the CNS, they could get meningitis, they could get an infection from the skin or soft tissue. If they have a central line, they can get an infection through the catheter. The urinary tract, they can get an infection there. Their lungs, very commonly we see pneumonia, obviously a bloodstream infection, and in the abdomen, they could get appendicitis, a gallbladder infection, things like that. And sometimes, a lot of times, actually, we don't find a source of infection in these patients. So sometimes it's a mystery why they're presenting this way. In terms of the different pathogens that they could get, so bacteria is the most common, gram-positive specifically, most common cause of febrile neutropenia, and gram-negative bacteremia is the most common cause of death, and that's because gram-negative bacteria is actually really hard to treat. A lot of times, our antibiotics are not very effective against the gram-negative bacteria, and that's why, unfortunately, patients die from it. Viral infections, commonly we see HSV, CMV, EBV, and of course, COVID-19. Fungal, you sometimes can see Candida. It's very common in any kind of mucosa. And sometimes we can even see it in the bloodstream, aspergillosis. Basically, it's a type of mold. We can sometimes see that in the lungs, in the bloodstream as well. And protozoan infections, that's pretty rare here since that's more of a tropical infection. So I'll talk about our case. This is Mr. P. He's a 61-year-old male with acute myeloid leukemia. You're working in the outpatient unit, and he's received consolidation with the protocol called FLAG-IDA. And he's coming in today just for an assessment. He's cycle 1, day 23. And you're reading through his notes. You see that in the notes, it says he has a PICC line in his left arm. His social history, he lives alone in a basement apartment, and he commutes with public transit to the hospital. His past medical history includes cardiovascular disease. He's had a CABG surgery in 2018. His high blood pressure and diabetes. Here are his meds. And he takes amlodipine, metformin, rosuvastatin, Cipro, fluconazole, valacyclovir, plocriperazine, and ondansetron. And he's done his blood work already, so you check his blood work. CBC today is hemoglobin 80, WBC 0.1, neutrophil count is 0.0, and your platelets are 52. So this is your, initially reading up on the chart on the patient. He's not here yet, so I have a question for you guys. What are the risk factors, just from reading his chart, that are obvious to you for him to develop febrile neutropenia?
I guess we could see in the chat too.
Yeah, I don't know if I can't see the chat, but you guys can just speak up. You don't have to.
ANC of 0.
Yeah, so having obviously low neutrophil count.
Big line.
PIC line, central line, yeah.
Is it basement, it's TPC?
Yeah, lives in a basement, takes public transit. So exposure to other people, lives in a basement, it could be exposure to molds and things like that. What else? Diabetes, good. Yeah, exactly. Having leukemia itself, definitely a huge risk factor. Anything else? Yeah, he's 61. He's right above that cutoff.
Yes.
There it says central line, I think.
Yeah.
Yeah, and just like, the fact that he's on flag ida chemo. I think we've covered almost everything. Yeah, just any, cardiovascular disease, because his heart might not be functioning to his full capacity. That's also a risk factor. So you guys have covered it all pretty much. Sorry. And then what are some potential sources of infection that you should be thinking about even before he walks in, that you should be looking for?
Respiratory?
Yeah, respiratory. And why is that?
That's one of the entryways.
Yeah, for sure. And just thinking about, like flu season, right? And taking the public transit, people are probably coughing all over the place. Yeah, definitely a big one. What else? Yeah.
So
PIC
signs
line.
of infections around the PIC line.
Yeah.
Swelling.
Yeah, signs of infection around the PIC line for sure. Anything else? Fungal. Yeah, for sure. Yeah, because he lives in a basement and depending on his, hygiene practices, definitely. Yeah.
Wounds or skin rashes?
Yep. Yeah, any kind of skin tear, wounds. Anything else? Yeah.
I'm actually not sure about this one.
No, go ahead.
What about hemorrhoids? People who have them, are they more at risk?
Definitely. Yeah, that's why we want to put the patients on good bowel regimens. So I don't know if people probably didn't hear online, but someone said hemorrhoids. So yeah, if a patient is very constipated, they're straining and they have, they may get blood through the rectum, that can definitely put them at risk for developing an abscess there for sure. Okay, yeah, I think we've kind of gone over all of it. So try to keep that in mind as you're anticipating the patient to come in. So he comes in and you're chatting with him and he sits down and he tells you that last night at home, around 7 o'clock, he had a fever, 38.4 degrees Celsius, lasted about an hour, and he decided to take Tylenol and he felt that the fever went away. He also tells you that the last 3 days, he started having a new productive cough and some runny nose. You take his vitals. His blood pressure is 129/75, pulse is 121, temperature is 38.5 degrees Celsius, his rest rate is 22, and his oxygen saturation is 95%. So obviously he is having febrile neutropenia. So before we move on, I just want to talk about some important nursing considerations. First things first, IPAC, infection protection and control. So I put on there a few elements, but I kind of want you guys to kind of talk about what would be important to consider in terms of IPAC with this patient or infection prevention and control.
Because he had fever and when he knows that he's maybe COVID.
Yeah, so COVID. Exactly. So isolate the patient, right? If available, bring them into a room, isolate them. And the precautions may be institution dependent. So at our institution, we would definitely start droplet contact precaution and even COVID precautions. I'm not sure if we're still doing that, but this depends on your institution, but somebody like him definitely droplet contact. So that means some kind of mask, either that's N95, depending on your institution, or just a regular face mask, face shield, gown, and gloves. So first things first, take the patient, put them in a room, make sure you have the proper PPE, and of course, hand hygiene with every patient. So the nursing assessment, what kind of questions would you ask him about his infection history and his symptoms?
Has he been in contact with anyone who's been sick?
Right. Yeah. So he lives alone, but maybe he had a friend over or he relatives had a gathering, the holidays. If he's near anyone who's sick, very good. Yeah. Anything else? Yeah. Onset.
For later isolation.
Yeah. Yeah. So he tells you it was last night, but maybe it's been going on for a couple of days. Sometimes that happens. If you don't ask, you don't know, right? Yeah. Good. Anything else? Bless you.
Any chills or rigors at home?
Yeah, any chills or rigors?
Fevers, right?
Yeah.
Is he been drinking? Is he
Mhm.
taking antibiotics?
Right. Yeah, so that's a good one. Has he been taking his medications properly? Because as you probably saw, he's on some prophylactic antimicrobials, and Melissa will talk more about that. Yeah, so basically, go over any kind of potential source of infection that we talked about earlier. And I have a slide. The next slide will go over all the signs and symptoms. All these questions are very important to ask. Vital signs, we already took the vital signs and we saw what they were, and I'll go over that again. What kind of physical exam would you want to do on a patient like this?
Wounds or open skin.
Yeah, any wounds, open
Like
skin.
oral, gum, if there's an infection.
In the mouth? Yes. Yeah, take a look in the mouth. Mm-hmm. Yeah, ask him about hemorrhoids. Yeah. Mm-hmm. Yeah, and take a look at his central line, right? Yeah, and sometimes it may be important to take a listen to his lungs. I know it's not something that we do routinely, but it's good practice. Take a stethoscope, listen to his lungs, see how it sounds, and sometimes it can be very obvious when there's an infection in the lungs. Okay, very good. Patient education, what are you thinking about? Maybe not right now, but just to keep in the back of your mind, what kind of patient education should you be giving someone like him?
No
Yeah.
Tylenol.
No Tylenol. Yes. Yes. Very important. The moment you have a fever, seek medical attention. So that's going to the nearest emergency department. Yeah. And if the patient asks you why do I have to do that? What would you say?
You scare them a little and say, well, no, you tell them the truth.
Yeah.
But you do tell them that it's actually a medical emergency and it could go very poorly, very quickly, and just let them know the severity of the situation.
Right. Yeah. For those online who didn't hear. So basically, yeah, like I mentioned, it's an oncologic emergency. So any point you have a fever, your immune system's not really there to help you fight it. So you need medical attention right away. And this could turn south very quickly as well. So teaching the patient, proper hand hygiene, oral hygiene, using a gentle toothbrush, but definitely still maintaining oral hygiene, avoiding any sick contacts, avoiding high-risk foods. So that means no sushi, no raw steak, that kind of stuff. Wash your fruits and veggies really well. Cook your foods fully, avoiding enemas, so nothing up the rectum because that can cause trauma and infections, and no shaving with a sharp razor because that actually causes micro cuts in the skin and that can cause infection. And most important, we already mentioned, is seek medical attention if you have a fever. So the signs and symptoms of infection, there's a whole lot of them. And the way that I remember it is by system. So I split it by system, and I think this may be easier when you're approaching a patient. So starting with the systemic symptoms, so that's fever, we already talked about that. Any chills and night sweats, that could be a sign of a systemic infection. And even falls and syncope, so LOC changes. Sometimes our patients don't present with a typical infection symptom. They may not mount a fever. So if a patient tells you, I'm feeling dizzy or almost fainted or I fell over, that could be a red flag. And then moving on to the respiratory system. So ask them, do you have any cough, shortness of breath, even chest pain? Sometimes can be a sign of pneumonia. HENT, so any headache, sore throat, runny nose, taste changes, mouth sores. The GI system, so nausea, vomiting, diarrhea, abdominal pain, rectal pain, we already mentioned that, the GU system, any pain when they pee, any suddenly can't pee, or any discharge from the vagina or a penile discharge, testicular swelling or pain, those can all be infections. And the skin, so any wounds and anything with the central line. So we do have to touch on sepsis really quickly. Sepsis is basically a body's mechanism and reaction to a systemic infection. And what happens is the localized infection goes into the bloodstream and it triggers a downstream inflammatory response that causes the capillaries to be more leaky. So the cells of the capillaries start pulling apart and the fluid in your blood starts leaking into the soft tissue. And that causes low blood pressure and low perfusion to the organs. And your organs start failing, and eventually this can lead to death. So why is this important? We want to really prevent this from progressing. So the early sign of sepsis would be any fever, tachycardia, tachypnea. So at this stage, it's called compensated sepsis. The patient's body is still reacting, responding appropriately to the infection, trying to mount an immune response. So this is still a reversible stage. Late sepsis would be when patient's mental status is altered. They have early signs of organ failure, so maybe less urine output, any hypoxia, blood pressure starts dropping. So at this stage, it still can be reversible, but it's definitely starting to progress. And this is the shock stage where they may have cool extremities, delayed cap refill, thready pulses, and hopefully you don't see anybody in this stage, because a lot of times this can be irreversible. Patients are often in the ICU, and very likely they could die from this. So it's important just to recognize these signs to really act quickly to prevent it from progressing. So we're back to Mr. P. We know that he had a fever last night. So even last night, he had febrile neutropenia. It's not ideal. He didn't go to the hospital, but he's here today. And you look at his vital signs. So his pulse is 121, temperature is 38.5, and respiratory 22. What stage of sepsis would you say he's in right now? Early, yeah. So he's having a bit of tachycardia. It's not extreme, but it's definitely a little high. Fever, and his rest rate is a little high. Oxygen saturation is still okay, 95%, but we will want to keep an eye on that in case it starts dropping. So initial investigation and management of these patients, first things first, make sure their ABCs are okay. This is very basic, but you never know. Some patients can really decline very quickly. Make sure they have line access. Maybe don't access it just yet in case we need blood cultures, but make sure they have something on board and do your IPAC precautions. Notify the provider right away, whether that's the on-call physician or the nurse practitioner. And if needed, escalate the care. If the patient's looking unstable, don't be afraid to call a code medical, code blue. There's no harm in that. So the initial investigations that might be ordered, CBC electrolytes probably would have been done already, but if not, they definitely need those. Creatinine, just to take a look at the kidney function, that's important to look at the organ function, but also some antimicrobials may need that level checked before we can give. Blood cultures for sure, so peripheral blood cultures as well as central, if they have a central line. And sometimes serum galactomannan may be ordered for high-risk patients like this patient. So serum galactomannan is a marker for aspergillosis, which is a fungal infection. Urinalysis, urine culture, any viral swabs. For him, he would definitely need a respiratory viral swab, check for COVID, RSV, rhinovirus. If he has any wounds, any sores in his mouth, we would probably swab that. And if he has diarrhea, then we would do a stool culture, C. diff. Imaging, usually we do need some kind of imaging. For Mr. P, it would be some kind of chest imaging, and this really depends on the institution. Ideally, a CT scan to check for pneumonia is best since it's very sensitive. but not all institutions can have that readily available. So a chest x-ray, is better than nothing. So that might be ordered. If the patient's having abdominal pain, oftentimes we'll do a CT of the abdomen. So it really depends on the symptoms that you assess for. And most important is starting that empiric antibiotic as soon as you can. And usually it's a broad spectrum IV antibiotic. And supportive care. So like I said, we don't want sepsis to progress. So we want to give the patient some kind of IV support. His blood pressure is still okay, but he's a bit tacky. So maybe a good idea to give him some fluids to kind of help with that heart function. And then symptom management. We want the patient to feel comfortable. With a fever, it's usually not very comfortable. So at this point, we've done all the workup. It's okay to give him some Tylenol to help him, feel more comfortable. And hopefully that can help with his tachycardia as well. Okay, I'll let Melissa take over now.
So as Jane mentioned, it's very important that we give the patients an appropriate antibiotic within the first 30 minutes to an hour. We have really good data to suggest that patient outcomes highly improve if we can get them treated as soon as possible. So I'm going to spend the next 2 slides talking about 2 different types of febrile neutropenia guidelines that we use at our institution. Our first slide, we're going to look at our low-risk febrile neutropenia patients. So these are typically our solid tumor patients and our lymphoma patients. So what we define as low risk for febrile neutropenia are patients who have a neutropenia shorter than 7 days, and their ANC naters never really fall below 0.1. So pretty short and not as profound neutropenia as our leukemic patients. So once we have the initial assessment investigations done, our next step is to figure out what is the best empiric antibiotic for our patients. So generally speaking, the cultures can be negative. However, guidelines do suggest we still treat with antibiotics until we can stabilize the patient. And because we're not waiting for cultures to come back to figure out what antibiotics we're using, we can usually figure out the common source of infections with febrile neutropenia are patients who are colonized with their own microbes. So these are your gram-negative and gram-positive bacteria we talked about earlier, and we are choosing a broad-spectrum antibiotic, such as what we see here, which is cefazolin and tobramycin we can usually add on. Alternatively, if a patient has penicillin allergy, we can treat with meropenem. Since this algorithm here is specific to our institution, other institutions you may see a combination with a fluoroquinolone such as ciprofloxacin or levofloxacin with the addition or not of amoxicillin and clavulanate. So if the patient has additional symptoms in addition to their fever, such as diarrhea, you may consider adding oral vancomycin. If a pneumonia is suspected, such as a case with Mr. P, for patients with lymphoma, we can add azithromycin. If the patient suspected to have flu, this patient might have the flu, we can add also Tamiflu or Tamiflu. If they're showing up with really bad mucocutaneous infection, so they have really bad mucositis despite having the appropriate prophylaxis, we can consider adding in acyclovir. If they have a line infection, we can add on some vancomycin, and if they're showing up with some cellulitis, we can also add in vancomycin, especially if the patient has a MRSA positive infection previously or colonized with MRSA, or MRSA is a concern in our local area. So those are common add-ons we can have. So the second slide here is the management in high-risk febrile neutropenia patients. So these are patients we typically see in our unit. These are your acute leukemic patients. These are patients who just had a transplant and still recovering. Very similar workup. However, the choice of antibiotics is slightly different. We tend to choose an antibiotic with anti-pseudomonal beta-lactam activity, such as your piperacillin tazobactam, or what we call tazozin. Other institutions you may see cefepime or imipenem cilastin or meropenem being used. That's dependent on your local recommendations and your sensitivities. So typically monotherapy is recommended. It has pretty good initial coverage. However, if the patient is looking very sick, so they're hemodynamically unstable, or they're at high risk for for being very ill, such as our patient, Mr. P, we would add in additional gram-negative coverage of using tobramycin. And in addition to that, if they're showing up with other infectious signs, like if they are coming in with what you think could be shingles, you could add in some antiviral there too. So going back to Mr. P, I'm going to look to the audience, and maybe if our moderators can display comments. If that's not possible, I'll just look to the audience here. Now that we have a good history and vitals for this patient, I like to ask, what should we do for Mr. P? I'll get a yes and no answer from the audience. Will we need to start empiric IV antibiotics? I'm going to get a hand raising here. So raise your hand for yes. I'm going to say majority of the people say yes, so we're just not going to entertain the no answer at this point. So yes, we've established we need to give him some antibiotics. The next question is, before choosing which antibiotics to use, what are some questions that we need to know before recommending antibiotics? If you can see from the slides, we already have the answers, but really we should understand if you have any allergies and his previous exposures to antibiotics. So you can see here, he's been on some prophylaxis. And I don't think we got an allergy history, so hoping he is not allergic to penicillin. And our third question is, what patient education do we need to provide moving forward? So I'm going to look to the audience. Aside from the IPAC considerations that we were talking about, like the hand washing, wearing a mask, what are other things to consider for patients who we're starting antibiotic on?
The importance of finishing
Yes,
antibiotics.
I know that's very important. Patients sometimes will stop taking it when they feel well. Maybe how about looking to the audience for another education point, especially now that we started antibiotics and we're sending him home.
Even experiencing side effects from the antibiotics,
Yep.
like diarrhea, or yeah, and if he has any of those, let us know so we can manage them.
Yeah, so we can make some changes, make some recommendations. Other things to consider is he may be starting on antibiotics. We're starting very broad spectrum, and if he starts to develop another fever, or the fever's not going away, it's over the weekend, he's starting to feel very weak and fatigued, unable to use the bathroom, that's education point where we want him to go back to the Emerge, or to call his healthcare provider ASAP, as the antibiotic we started may not be the best one for him. So those are a couple of education points. So now that we've talked a little bit about how to manage patients with active febrile neutropenia, what can we do to actually prevent it? So I'm going to look a little bit at primary prophylaxis. So we want to really prevent the initial episode of febrile neutropenia. So there are a couple of strategies we would employ. I'm going to go over the use of GCSF, some antimicrobials, and vaccination. So the algorithm you see up here is what I pulled from our Cancer Care Ontario Febrile Neutropenia Guidelines from 2021. So this talks a little bit about whether GCSF is indicated and for which patient population. So it's really divided based into patients who are at the highest risk for developing febrile neutropenia, those who at a greater than 20%. Then those are the moderate patients, are between 10 and 20%, and the low risk patients who are at less than 10%. Patients at the highest risk for developing febrile neutropenia should really be treated with primary prophylaxis. So given some GCSF with their chemo, not together, but usually greater than 24 hours afterwards, depending on the treatment. Patients who are at intermediate risk are further stratified into individual patient risk factor to whether should be receiving a GCSF or not. And those patients who should receive it are patients who are over the age of 65, getting greater than 85% relative dose intensity treatment, extensive prior myelosuppressive systemic therapy, prior radiation to the marrow, bone marrow involvement in tumor, HIV, neutropenia, prior febrile neutropenia episodes and patients who have low performance status. Those are the patients who are intermediate risk and have these additional risk factor that should receive some GCSF as primary prophylaxis. Patients who are at low intermediate with none of those risk factors, and those patients of low risk of developing febrile neutropenia, those less than 10% should generally not receive GCSF upfront. However, I'll talk about that more in the secondary prophylaxis later. So quick thing, because COVID-19, now we live in a post-pandemic era, is to really think about COVID-19 with patients presenting with fever and cough and chills and runny nose. Some of the questions that we may get is, should we get a COVID vaccine? And generally speaking, yes. The next question is when we should be receiving that vaccination. So patients planning to receive chemo should receive vaccination for COVID-19 at least 1 to 2 weeks before starting chemo. If the patient's already on chemotherapy, we should look for them to have some sort of count recovery. So usually right before their, like a week right before their next anticipated chemotherapy treatment. And patients who've just received a stem cell transplant or CAR T cell can be offered COVID-19 vaccination starting at least 3 months after therapy. The caveat with this whole slide is everything is going to change. I know this is a recording, so please refer to your most latest updates on vaccinations, because I know a lot of this information will be evolving throughout the years. With COVID, if a patient is actually COVID-19 positive and recommended treatment with Paxlovid, a couple considerations when they do start on it is overlapping toxicities and drug-drug interactions. It's very common, and there are a lot of interacting medications. Thus, the best choice right now is to actually speak to your pharmacist, and they can determine what can be done in terms of monitoring or modifying drug interactions and overlapping drug toxicity. So I've included a resource here as a drug interaction checker, specifically with like Paxlovid. So in terms of primary prophylaxis and secondary prophylaxis of antimicrobials, I kind of divided up into a couple sections here. First, I wanted to talk about prophylactic antibiotics. It's still being recommended for patients who expect to experience neutropenia longer than 7 days. The use is slightly controversial, especially now that there is some conflicting data in terms of overall survival, but the guidelines still do recommend antibiotic prophylaxis. Common drugs you're going to see are fluoroquinolones such as ciprofloxacin or levofloxacin. Usually it's administered for the duration of the neutropenia. So until the patient recovers the count, they're going to take it until then. So that's a question patients might have. They're being asked to take a preventative antibiotic. So they're like, I know I don't have an active infection. Why am I taking it and how long? So typically a good education point is just talking to them about the risk of developing febrile neutropenia and infections, why they're taking it, which is to prevent developing febrile neutropenia, and how long is typically until they can recover counts. So if they come back for twice weekly blood counts, they've noticed that you've noticed that the patients recover their counts, this is a good conversation to have with your nurse practitioner or the on-call doctor as to when to stop the antibiotics. The second thing I'd like to talk about is PJP prophylaxis. So these are really reserved for patients on fludarabine-based treatments or alemtuzumab, or patients treated with PI3K inhibitors, or for our patients in the Dana-Farber protocol, those who are receiving prolonged course of corticosteroids. We like to give these patients sulfamethoxazole, trimethoprim, or Cetra. Usually you can do double strength or single strength. The double strength is 3 times a week, single strength is daily. So with antivirals, we really only reserve those for patients at risk for developing varicella or herpes simplex infections or reactivations, and specifically patients receiving treatment containing proteasome inhibitors such as Velcade in multiple myeloma, or fludarabine containing regimens such as FLAG-IDA. And these agents such as acyclovir or valacyclovir should be administered until patients recover their counts. And antifungals are really only reserved again, in patients with high-risk febrile neutropenia who we anticipate to have profound and prolonged neutropenia. So these are your acute leukemic patients who just received intense induction chemo or patients who just are coming out of transplant. We would consider agents that would prevent against invasive fungal infections with like candidiasis or aspergillosis. Unfortunately, the types of agents we like to select are the azoles, and these are often complicated with many drug-drug interactions. So again, talk to your pharmacist if you have concerns, if patients have questions about drug-drug interactions, and also to educate patients on intolerable side effects, what to look out for, and also monitoring may be required. Last but not least is vaccination. So we did talk earlier about COVID vaccines. I'll go into a little bit more details about other types of vaccine. So usually the conversation I have with patients with vaccination is, what should I be getting and when should I be getting it? Vaccine, I want to address the when should I be getting it before getting into what should the patient be getting. So vaccine administration should be timed carefully around when we would expect the patient's immune systems to fall. So vaccines, as I said earlier, should be administered prior to the planned chemotherapy. And live vaccines should be generally administered no earlier than a month prior to chemo, and inactivated vaccine should be administered around greater than 2 weeks prior to immunosuppression. But we find ourselves in between chemotherapy. We generally expect patients to have recovered some of their counts before getting vaccine, to have some sort of coverage to be able to mount the immune response to get the benefit. So once a patient has completed their entire schedule of chemo, generally 3 months after they recovered all their counts is when we would stick with the normal schedule as we would with immunocompetent patients. However, there are some types of therapy, such as B-cell depleting therapy, where you would have to wait longer than 6 months. In terms of what patients should receive, generally speaking, we can recommend the flu vaccine. Most cancer patients should be getting their flu vaccine. However, some patients, such as our acute leukemia patients or patients who receive blinatumomab or CAR T-cell, those are patients who may not derive the best benefit from a flu vaccine, but they still should receive it, which is why the next question to bring up to them and their caregivers is having their caregivers be vaccinated against the flu as well. So then that way they get a bubble of protection. Other vaccines to consider are like pneumococcal vaccines, herpes zoster vaccine with Shingrix, and I think we have our odor Zostafax. And as I mentioned before, COVID vaccine, and more recently we had the RSV vaccine, but I think in terms of indication at this time for our adult patients, really only for patients who are over the age of 60. So this may change later as there are more indications available. So secondary prophylaxis, what can we do for patients who still develop febrile neutropenia despite getting the appropriate primary prophylaxis? So it's kind of divided up into two sections. What if the patient has febrile neutropenia but did not receive G-CSF? So those will be your low-risk febrile neutropenia patients, but they still develop febrile neutropenia. We would consider using G-CSF in their subsequent rounds of therapy. And if depending on the goal of therapy, whether it's for palliative or adjuvant, a dose reduction to the chemotherapy might be warranted. The second part is if a patient had febrile neutropenia despite getting primary prophylaxis and G-CSF, you don't really have much options aside from maybe adjusting or changing the treatment to a less myelosuppressive regimen, or having a dose reduction, however, continuing to get G-CSF. So I wanted to kind of talk briefly about ASP, or Antimicrobial Stewardship Program. So you may wonder how we came up with these guidelines. We have our local ASP team to thank. They have taken the latest guidelines and really tailored towards our local resistance pattern, our formulary, and provider preference to create what we see here today. Our guidelines are due for an update soon, so hopefully look out for the next year or two. The benefit of a good ASP program is to help choose the best antimicrobials for our specific patient population. Hopefully it will help decrease the incidence of resistance, reduce the development of resistant bugs, and also improve overall patient care. Many centers are moving towards having an ASP program, and even with smaller institutions, they may be partnered up with other institutions to have an ASP program in the community. So I really encourage you to reach out to your local ASP program to understand more about your local guidelines and recommendations. So last but not least is some additional resources we pulled together. As I displayed earlier, we have our local ASP guidelines from the UHN and Mount Sinai. CCO has put out a great guideline that was last updated in 2021, and I've included the link here, and BC Cancer as well, and I think it might be a little bit older. So otherwise, we are at the question period. Any questions? And I don't know from the chat how we can see that. I can see.
Awesome. Thank you so much, Jane and Melissa. So don't worry about the questions. I can get that information to you. So yeah, for anybody who hasn't had the time yet to post their question, you can still do so now using the Q&A box in the Zoom panel.
Anybody in the room? Yeah, we got 2 questions in the room.
Yeah, for sure.
We'll repeat it here.
So when you were going through the antibiotics, you didn't mention, did you mention Tazo? Okay, but I heard cephalexin, but we don't get that quite as often, or we give mostly Tazo.
Here, we can go back.
Yeah. So the question is whether tazocin or piperacillin tazobactam is in our guidelines. So for our high-risk patients who are usually our acute leukemia patients or post-transplant, we typically will recommend tazocin, or abbreviated from piperacillin tazobactam, as our monotherapy, and we may add in tobramycin for patients who are looking very ill, might be hemodynamically unstable. And I think, did she ask about cephalexin or?
Yeah. So what do we add that in? Because we don't see that as often.
Cephalexin.
Oh.
Cefazolin.
Oh, cefazolin.
Yeah, cefazolin.
Okay, it was like a little bit. So that would be actually more of our lymphoma and solid tumor patients. So I know this team here is really seeing our acute leukemia high-risk patients, but if we have, let's say, a breast cancer patient who's getting dose-dense chemotherapy, they're coming in with a fever, typically our guidelines will recommend cefazolin. And then if they were looking really ill, we'll add in some gram-negative coverage with some tobramycin. Does that answer your question? So it's actually our solid tumor and lymphoma patients.
We'll see.
My question is that you said that when we are giving the prophylaxis antibiotics, we are going to look into the ANC number. Is there any guideline as where ANC has to stand before we stop antibiotics?
I think as long as we recover to, I think our preference here is over 1.
Yeah.
And I think it is included in some of our treatment plans. So at that point, we can reconsider whether to continue the antibiotic if there's a clear reason why they should be getting it. Maybe they had a really bad fungal lung infection, they're about to go into transplant. There's a discussion that maybe we should just continue it because fungal infections are really difficult to treat. If they're getting the antibiotic for even an active infection, we should maybe continue until they finish their course. Those might be some additional consideration before we just say, let's just stop it altogether.
Yeah, so a lot of our leukemia patients have previous infections. So I think that's what complicates things a little bit. If it's a primary prophylaxis, like never had an infection before, and it's just part of the protocol, then I think once their neutrophils are at 1 and that's gonna keep going up, then we can probably stop it. But if they've had a previous pneumonia, maybe just only a couple of weeks ago and their neutrophils are 1, but you're not really sure, may go up, may go down, and we may continue those antibiotics just based on their infection history. Yeah. Yeah.
So is there another question? Because I have some that came in prior that were
okay.
Maybe let's do that and then
we'll get
to
the
online one.
Yeah, we'll do the online.
For sure. And just a reminder, if people do have questions, just pop them into the Q&A section. So yeah, a few questions that came in when people were registering. So someone was asking, when is it appropriate to remove or leave a PICC line in the case of sepsis or febrile neutropenia?
I actually just looked that up this morning. So there's no standard guideline around that. Usually if we don't have cultures back yet and the patient remains extremely ill after 48 hours, we haven't found the source of infection, then it's probably a good idea to remove the PICC line, since PICC line associated infection is actually extremely deadly. If we do have blood cultures back and they have like candidemia or a staph aureus or MRSA in the bloodstream, then it's a good idea to remove, because those microbes tend to be very sticky and they tend to stay in the PICC line and they're very hard to treat. So it's normally we don't need to remove it. In other cases, we can usually keep the PICC line in.
Awesome. Thanks so much. So someone asked if there are any real-time audits being done in the adult world to ensure febrile neutropenia times for blood work and antibiotics are being met.
You mean like data? I guess data collection. I think that's very difficult. Those guidelines were recommended actually by the American Society of Clinical Oncology, or ASCO, to show that the longer you take, the higher the chance of mortality. I think it would be a good idea for institutions to be tracking that. We are actually tracking that at Princess Margaret, but manually. The MP group is doing that. But you're right, that's probably a good thing for maybe Cancer Care Ontario to be looking at. I don't
accreditation. I know.
Accreditation. I don't think they are though.
No, but we do know that the data is very strong that we need to get antibiotics in within an hour, no later than an hour. So I wouldn't delay
as much as possible. Yeah.
Awesome. Thanks so much. And then another question, what is the most important information that you can share with a patient that is likely to experience a febrile neutropenia? So I think you touched upon it, but what would you share to a patient?
Yeah, so usually what I tell patients, especially high risk, like acute leukemia patients, but even, solid tumor patients who are on chemotherapy, especially with a week to 2 weeks after their chemo, maybe a good idea to check their temperature twice a day, morning and evening, just to get a baseline, make sure there is no spike. If temperature is over 38 degrees for an hour or 38.3 at any time, go straight to the emergency room. So that's actually very important. Here we have a fever card that we give patients. It's basically a card that just says, if you have a fever, go to the emergency. And then on the other side of the card, it kind of has instructions for the emergency provider, whether or not they decide to use it. But basically it tells them that, they're high risk and they have febrile neutropenia, so they should start empiric antibiotics. This card kind of is like a trigger to remind the patient to be very vigilant about febrile neutropenia.
And I guess around the Tylenol usage, because I think patients always have a question, can I use Tylenol? Can I use NSAIDs? Usually NSAIDs, we would probably ask them not to use. And Tylenol, if they have to use it, sometimes we would recommend taking a temperature before each Tylenol use, just so they're not masking a fever.
Yeah.
Great, thank you so much. So it looks like that's all the questions that came in. If there are questions in the room there with you.
Yeah. Rachel?
Like some of our patients, they're elderly and very frail, and they have prolonged neutropenia for months.
Yeah.
And also at the same time, there's dependence. Like because they're neutropenia, do they just be on like oral antibiotics forever?
So the question coming from the audience are for patients who are elderly, who are profoundly neutropenic for an indefinite amount of time, it seems. Do we keep these patients on oral antibiotics?
That's a good question.
I think at this point, going by guidelines, it's a yes. However, going by real world, not data, but just real world anecdotal, it's a conversation to have with the patient, with their care provider, what long-term antibiotic use may mean, whether it's side effects, potential for drug resistance. And sometimes for a patient, it's just having to take it every day, and could be interrupting their schedule. It might interrupt other medications they're taking. That's a good question.
Yeah, I agree. So basically, I would discuss with the patient, usually kind of shared decision making, because you're weighing the risks and the benefits here. The patient has never had an infection before, and they are another aspect I would say is like health literacy, like how much are they able to understand, the significance of this, and how is their own, personal care, like can they take care of themselves? Are they watching for these symptoms? Those patients, I might be okay with not necessarily giving them, antimicrobials forever kind of thing. But a lot of other patients that may be at risk, like Mr. P, who lives alone, lives in a basement apartment. And if he is good at taking his medications and he's not having side effects from it, probably a good idea to keep him on those prophylactic antibiotics.
And other consideration in addition to that is like, what is their plan? Are they going to be transplanted? Are they going for CAR T? If they're going to go through that rigorous regimen and they want to be cured, some of their physicians may elect to be very aggressive and keep them on all these prophylaxis just to kind of keep them healthy until they can get the curative intent therapy. So that's something.
That's a good point.
The one that I'm referring is they are not going to.
So palliative patient.
Yeah,
Okay.
Palliative.
ASAP or like monthly
Yeah.
ASAP.
Yeah, those patients definitely is a discussion with the patient. If their goals of care isn't, cure, which a lot of our patients are not, but it also depends on the direction they're going in. If they're kind of going in the palliative direction, going into we're just supportive care, the AZA or whatever we're giving is just, kind of like a last ditch effort. Those patients, I may be more inclined to remove some of the polypharmacy if they're on a whole lot of meds. So yeah, it's a good question, but I would say it depends from patient to patient.
Yeah, and it really goes back goals of care. Like, have they had that conversation?
Exactly.
Because that involves reducing the amount of extra medication they might take. So,
Great question.
I actually have a question for Jane.
Sure.
So as
CRS question,
at least I've kind of told you ahead of time, but understanding there's a lot of new therapies out there that like even like high dose cytarabine, which is not new, but some of the bite therapy, CAR T, there are overlapping symptoms of fever. And what do you do with those patients who come in on this new therapy with the expectation of, is it febrile neutropenia or is it fever related to their treatment? How do you manage and how do you triage these patients?
That's a really good question. So a lot of induction patients like 3+7, they're on cytarabine, that can cause fevers. So that is it's not a straightforward answer. So you would have to kind of look at the whole picture. So it's the patient on day 1 or day 2 or day 3 of chemo. So they just got cytarabine. Did they take their medication that lowers the temperature? Have they been taking their medications properly? And if those are a no, then you might have a suspicion that this could be cytarabine-induced fever instead of febrile neutropenia. However, you cannot rule that out. So it's always a good idea if the patient's having fever, they're neutropenic, you still have to do the infectious workup, because you can't tell just by looking at the patient if the patient's having an infection or not. As with the other ones, like if they're having like CRS, that's also it's actually a very difficult diagnosis. CRS, it can have very similar symptoms to sepsis. So those patients tend to be admitted and they're usually quite sick. And again, it's the timing. So did they just get blinatumomab for the first time? Did they just get CAR T? And the timing of treatment to onset of symptoms. And again, they still go through septic workup. So regardless, we still go through septic workup. It's the management afterwards. And usually they're still started on empiric microbials. And if after a few days, negative cultures the fevers are still there, then they start treating them with things like steroids and things like that for CRS. So it's a difficult diagnosis.
Yeah, I didn't mean to put you on the spot, but just, with all these new therapies to consider, like these are additional, maybe overlapping toxicities too.
Yeah, so I take home messages, always have to rule it out. You always have to rule out sepsis. Yeah. Any other questions?
Last chance. You can't ask more questions after this. I'm kidding. I'm kidding.
Are there any more online or?
Let me just double check. No more online. So if there's no more in the room, we can conclude this session.
Okay, thank you.
Thank you.
Right.
For overtime.
Yeah,
Thank
perfect.
you again for joining us today.
Yeah, well, thank you all so much for attending this last series in our 4-part series, the role of nurses in recognizing and addressing oncologic emergencies and leukemia and lymphoma. We are very happy to have been able to partner with Princess Margaret Hospital and to deliver these sessions. And I just wanted to give a very special thank you to Shannon Nixon, Graham Dozwa, Cindy Murray, Matthew Somerset, Jane Lee, and Melissa Lowe. And thank you all thank you for everyone who participated in these sessions. And just a reminder, they are all available, and this one will be available soon on our continuing education program platform. So please do visit Blood Cancer continuingeducation.ca to access them. If you don't mind changing the slide, I think we just have a few more slides to share. Awesome. So there's a website there along with the QR code. So definitely recommend you all checking that out. Next slide, please. So although this 4-part session has ended, we do have some upcoming live training. So the next one's going to be taking part on January 23rd of 2024. And it's going to address the needs of transgender and gender diverse people in our healthcare system. So definitely recommend registering for that one. We also have a webcast that's going to be taking place tomorrow, December 14th, and it's going to be new treatment guidelines for chronic lymphocytic leukemia, CLL. So definitely also register for that one as well. And then next slide, please. We would like to thank, this event was made possible thanks to the support of AbbVie. So thank you very much. And next slide. I'd like to remind everyone that we are here to help support the blood cancer community. Do not hesitate to order our tear pads. They are completely free and we can mail them to your healthcare center. And then contact us if there's anything that we can do to help support you. Please note a short survey will be sent to all participants after the webcast. We would greatly appreciate you taking a moment to fill it in as it helps us offer the most valuable information in the near future. And with that, I just want to thank everybody again for participating, and I hope you have a lovely rest of your day.
Thank you, Charlotte.
Thanks, everyone. Take care.